All right, it's 5:30 on March the 24th. Mike, do we have a quorum? Can I begin? I'd like to start on time.
Sure. Yep, everybody's filtering in here. So welcome everyone. Module 13 Zoom session. Dr. Neil Kamal-Soros from Western Med. No delays tonight. I know I've been sending a lot of emails, but if you have any questions about what's on Canvas, let me know. Most of the links to everything are right on the landing page there. So I think that's my only announcement. So Neil, go ahead, take it away.
Okay, thank you.
Sure.
So I've been doing this for, this is my third year with the LEND long-term trainee cohort. And this, for obvious reasons, seems to be the most excited people are about this one of these particular topics. And I didn't think it would get to that, but I'm glad it did, because I think it's high time that telehealth was recognized as a mainstream way of delivering care. Um, I know everyone's very eager to get to that, but given that we have two parts, I'd like to spend 15, maybe 20 minutes on the emerging technologies part, and then spend about 40, 45 minutes on the telehealth part. In particular, I wanted to know from the group, and this is the same questions I pose every year, is think about how technologies, wearable technologies, usable consumer technologies are making lives better for individuals with disabilities, either in your field that you're directly aware of, or in other fields that you've noticed as part of your interdisciplinary training, things you may have heard about, and then we'll try and see how those apply or not to your fields. In some cases they are obvious, in some cases there are barriers. So I wanted to spend the next maybe 15 minutes so asking the group. Last year we had some incredible feedback. We learned about technologies that individual trainees had seen in their work that we were not aware of, and I've actually added those in. So some of the resources in the presentation that I mentioned, including those from the University of Michigan, etc., were a direct result of the Zoom session last year, where the trainees said, "Hey, did you know?" And we didn't know. And so we added those in. So I am absolutely glad to continue to update the presentation based on what your cohort knows. So let's sort of go around and people chime in about wearable, usable, off the shelf technologies. I want to just make a clarification. Last year, this question came up. We are not talking about augmentative communication and other types of prescribable technologies that speech language pathologists, special educators, and all know about. This is more emerging tech. AAC has been around a long, long time. It is nothing emerging anymore. I was using augmentative communication devices with my patients with cerebral palsy in 1998. And so it is not anywhere remotely emerging or brand new. But we're talking more about some of the novel things that are out there. So I wanted to sort of go around the group, ask you guys, what have you seen being used? How's it working? How's it improving access? And then counterpoint is if anyone wants to talk about what are the barriers for your clients and how it may not be currently applicable because of those barriers. So anyone can take it away.
I'll chime in. I haven't actually seen this employed yet, but I did read an article which discussed the use of a wearable technology, like such as a bracelet, which was able to effectively predict, it would measure biometrics and then effectively predict and sound an alarm prior to in individuals with autism prior to a behavioral outburst or incident. So it sort of was reading their biometrics and could sense the heightened state and then would give you kind of a warning.
Interesting.
Yeah, again, I haven't seen it in use and I don't know what the sample size, but it said it had like a pretty good success rate in terms of prediction. It was like 85% or something like that.
So I'm curious, Michael, it would have to be paired with some sort of intervention that then can be used effectively, almost preemptively, because merely by the feedback it provides, whether it be tactile, auditory, visual, whatever, an individual would have to change behavior, and that is not intuitive. It would have to be taught. So I'd be delighted if there's any way you could shoot a link to that article and I can delve further. I have used wearables in the past, and I have tried to use wearables in the past for a variety of things, autism included. And I think one of the limiting factors is that not all wearables are made the same. Not all of them have like sensitivity. Not all of them are affordable. And so when research projects get done, you have to be very careful about analyzing the literature, because different companies and different things are different. And so you've got to be careful. Are we talking about off-the-shelf wearables, Fitbits and things like that? Are we talking more high-end, which you can then pair with some sort of device? Is the data being sent to the clinician? So a lot of very important questions with wearables, because it's exploded so quickly. But with that, the clinicians have lagged behind. They haven't been doing wide-scale studies. They haven't been providing a lot of preemptive advice about use of wearables. People are using wearables for sleep tracking. They're using it for a lot of things. But what's lacking is the simultaneous rigorous approach of science to keep up with the explosion. So most clinicians and providers are playing catch up and reactive type of guidance. Oh, I don't know much about that. Let me look into it. Or I'm not sure. And the same can be said about, medicinal uses of marijuana and things like that. Rapid consumer adoption, not accompanied by robust clinical assessments and guidance. So I think you have a good point. I think it's great, and Michael has shared that. Looks like it's in Newsweek, and so that's great, but how many clinicians are going to share information with clients based on a Newsweek article? What I'd like to see is this very same thing be published at IMFAR, at the conference, or in the journal Autism or something like that, where we can talk about sample size and stuff. So great first start, Michael. Anyone else want to chime in, please?
Hi, this is Isabella. I'm on the phone, so sorry if I'm not showing up. I'm getting my PhD in kinesiology, and I'm also a medical student, and I've been fortunate enough to shadow with Dr. Felt at her sleep clinic at U of M. And when I was there, I learned a lot about sleep disorders in pediatric medicine, and she was talking that a lot of her patients have autism, and it can be difficult to work with the parents because oftentimes they don't really know when exactly the kid is going to sleep or how high quality it is. And so in kinesiology, we have these things called accelerometers. They're like $350 or something, and there's a ton of peer-reviewed, evidence-based research to support their validation with polysomnography in terms of sleep studies or sleep quality measurements. And I don't think that it's being used in clinical practice, but I was wondering why not. So that was one thing I was thinking about. And the other was I had a family come in for a study who had it wasn't like a Fitbit, but it was some sort of I don't know if it was a chip or if it was a bracelet, but somehow it had a GPS system on it. And so their child who had autism and who often eloped, they could just look on an app to make sure that she's where she's supposed to be and she's safe.
Yep. So excellent point, Isabella. I want to bring that point, and I may have an answer because I was working with kinesiology and engineering, and we did some research into monitoring activity using accelerometers versus what is called COT, common off-the-shelf devices. Accelerometers, in their true sense, the ones that were used in studies and in the past, both for ADHD and sleep studies, are very bulky, a little expensive, and they tend to have to be downloaded and not as easy now as sending data to the cloud, sending data by Bluetooth and stuff like that. So they're still the gold standard when it comes to certain types of movement monitoring. But I think their bulk, some of them were pretty heavy, and they had to be either on the wrist or the ankles. And the newer ones, what I'd like to see is a lot of studies which are validating some of these devices right off the bat against accelerometers. I have no doubt. Now, you have to remember, one of the most accurate and sort of easy to find, inexpensive accelerometers, every single one of you has. This thing is incredible when it comes to getting both in terms of speed and deceleration and everything. They actually have one inbuilt in all of these phones. The trick is, of course, taking the data and making it usable, because there's a lot of noise. There's a lot of, because data is being collected every second. How are you going to filter? You're going to have to write algorithms to then sort through that. It's a lot like people who have continuous pulse ox or stuff like devices from home. You're going to get million points of data, and as a provider or clinician, you're going to have to figure out what is important and what is noise. And I think that when somebody's walking around with one of these and you're trying to measure their movements, you don't also have a camera on them to know. In fact, one of my colleagues, his wife had a sensor on her, a wearable sensor. They were testing it out, safety things. He was trying to work on how can we prevent falls in the elderly population. And he had written a program by which if the position changed rapidly over an X amount of time, then it would send a message to either the provider or 911. Well, he was at work and he got 6 rapid of these of his wife, and he freaked out and he called her, and she was doing yoga and she was exercising. And so you see the risk of false positives are huge, because if you don't know the context in which data is being collected, you're going to overreact. But excellent point on the accelerometers, and I see people have put stuff in. Michael's talked about CTE prevention, and yes, absolutely right. They've put some accelerometers in helmets for professional athletes. The problem again is how do you get stuff in day-to-day life? Just how do you make it inexpensive? How do you make it accessible? Seizure detection is a big deal. I agree. Reese pointed that out. One of the things that they do is certain kids who have what are called the vagal nerve stimulators. They act almost like, okay, they sense that something's happening and you're able to deliver. So they've had that for a while, but of course, it's a surgical procedure, it's cumbersome. It'd be really cool if you could just wear something on your wrist that is able to detect, but it's hard because seizure activity is happening here. How are you going to wear a type of a device that captures? It would have to be, and I've actually seen this at trade shows and at the American Telemedicine Association, wearing a mobile EEG cap. But the person who had developed it hadn't yet figured out how to untether it more than 6 feet. They had them connected to a device which was capturing it. So you're going to have to walk around with a briefcase with a cap on your head that's capturing this, right? So you've got to talk about technology not only being accurate, but also user-friendly. I mean, and that comes to the whole point about, the matrix that I had put in there is all technology has to be usable, has to be accessible, has to be consumer-friendly. It can be accurate and nobody can use it. Then what is the point, right? Or it can be easily available like a smartphone but you don't know how accurate the smartphone's data is when it comes to its accelerometer. We trust its GPS like anything, right? So we trust one of its sensors very well. We haven't figured out how to trust its accelerometer as well. So that's really important. Ethical and legal guidance question from Jessica. That is absolutely true. And the reason it's a problem is because these devices could be worn across environments, across different legal frameworks, right? If you wear it in the school, you're bound by school regulations and FERPA and privacy issues. You take it into the home, the question is, who has the right to see your movements in the home? Do you allow your provider? Do you allow your provider unfettered access or limited access? So I had a research study with one of my engineer colleagues where he had wired up people's homes with small cameras to detect behaviors and tantrums in the home and look at proximity control and stuff. They had to sign a 8-page waiver consent form because the risk was, what if they slap their kid on camera? What is our obligation to notify Child Protective Services? What is our obligation to keep the child safe? What if people were doing drugs in the home, creating an unsafe environment? We're doing research, but we had all of these. Can you imagine what regulations they'd have to be if you started to access a person no matter where they were because you wanted accurate data? So I really appreciate that, Jessica. You're absolutely right, is we don't have enough. But at some point somebody's going to do it, because the trade-off between access to data that's important and protecting the privacy of people, there has to be a balance there. You have to know what your limitations are and understand that families have to be willing to share this. Now, I'll tell you, research studies have showed that families, contrary to what the regulations say, are absolutely willing to give up their privacy if they believe it helps their child. There have been lots of studies that say families will say, I will sign, you're allowed to do X as long as. But the problem with research is you cannot guarantee that there's a benefit, right? A lot of research is exploratory. You have to say there's no direct benefit, but this will help science in general. But just so you know, families are absolutely willing to waive their privacy if they believe that there's some, altruistic or something. So it's not, privacy is important, but families have told us through research that it's not as important as we as clinicians and researchers believe it is to them. Okay, we'll spend another 5-6 minutes on this. I'm sorry, because we have so much in telehealth, particularly in today's day and age. Other thoughts? I want one more person to just talk about, let's talk about barriers. We've talked about some examples. I want to hear from you guys about barriers. Let's say there was an awesome device tomorrow that's privacy protected, wearable, and cheap. What do you think the barriers are going to be?
I know a lot of my patients are premature, so a lot of the parents are accustomed to being monitored in the hospital using, continuous pulse oximetry and just always getting all this data. And they usually send kids home without any sort of monitors. And a lot of the parents I see will go out and buy a pulse ox and some kind of outlet that they'll go out and buy. And what they found is that those don't change the outcomes. And secondly, they increase parental anxiety. So, just because you get all this data doesn't mean it changes how your child does. And in fact, it can make quality of life worse for the families involved.
And that's an important point. Barriers don't have to just be access barriers. The barrier to using something is its usability. So for example, coming back to the seizure thing, if you knew when somebody was having a seizure or what activity they were engaged in, how often do you think the neurologist is going to change their plan? How often do you think that they change the medication, things like that? I would be curious, because right now, they put them in the hospital, they get an EEG, which may or may not show something. They look at the EEG, go, okay, let's do this, that, and the rest. It'd be really awesome if they had a lot of data that's been filtered appropriately. But I wonder if their training, see, it goes back to the training. You guys are awesome because you're on cutting edge. If a neurologist is not used to a practice by which they change their practice real time, how do we expect that they'll actually do it? How do we assume that they have the training and the knowledge to, in real time, see a child having seizures in their home on their phone as they have the app, call the parent and say, what's going on? Go ahead and do this, because medications are not real time active anyway, unless you're going to abort it with, seizure medicine that you give per rectal, which parents know to do anyway. So as Megan was saying, do we add anxiety by having little twitches on this monitor that the doctor's seeing, where they know only the important twitch is the one that you can see, and you abort with the medicine? So, we have the risk of too fine granular data sometimes may look awesome. We like to know things, but how practical is it? So that's an important barrier, right? It's use of it causing anxiety, but not changing care. Another one I'm thinking is we rely on Wi-Fi, broadband, and a lot of connectivity to transmit the data. So if somebody's in the home and they have a Fitbit and you want to know what's happening, let's say you want to know if they get more active and autism and things like that, how is the family supposed to send this data to you? Like, where is it streaming to? How are they uploading it? I right now I'm struggling with some families who do not have the bandwidth in their home. Yes, I know in emergency situations like this, a lot of companies are delivering short-term free bandwidth, but outside of a pandemic crisis, does somebody in the UP have broadband access that they can robustly send this data? Does somebody have the technology? What if you have a family paying by the minute or the text? I have families who, rather not you call them, they can send a text that per text and things. So we have to think about prescribing or assigning technology when the technology is not really all in one. It's not like you can send all the data. Everything relies on a sequence of events, right? This collects it, sends it to this node, which then uploads it. And so you need to have all the pieces in the chain, even the accelerometers, the information has to be downloaded. In the old school days, they download it manually. Now, if you want it uploaded, you certainly need to have the ability to send large amounts of data. So it's interesting. Michael had a question, how do you securely transmit data? So that's the issue, right? You have to have a portal. You have to have it securely sent, because the data would have to be stamped with the person's name or ID number. Because if, let's say you have 10 patients or 10 clients and you're trying to track them all, you have to have some master list which says 11603 is Michael, 11906 is Megan, right? Otherwise, you're going to get these streams of data and you're not going to know who is who. So you've got to have a way by which it's secure, which means the institution is going to have the bandwidth. It's going to have the server to store it. I'm telling you, video takes up a lot, which is why we don't store video. Still pictures, okay, but video, no. So what about massive amounts of point data? Point data is not as bad. So if you get blood, let's say blood pressure or blood sugar, 1,000 points of blood pressure is not going to take up a lot. It's just not. But what about 1 million? What about 10 clients of 1 million, right? Where's that going to go? So that's a really important point. So I know it's a little truncated compared to in the past, but let's move a little bit to telehealth. And I know, Mike, you had said that this group has had a preliminary conversation on Friday. Can you tell me what the content is so I don't repeat myself?
Well, it came up throughout the day, just because, and particularly Dr. Turner, I don't know if Jane's on right now or not.
Yeah, she is.
Okay. I don't know, James, if you wanted to chime in on this, but we've been talking about it because it's, of course, now becoming quite the issue for some medical professionals and institutions. It was just kind of talking about how that's emerging. Dr. Turner was talking about her experience with it in East Lansing as well. And I'm actually going to post the link. Michigan Health Endowment Fund is they're turning their conference to a webinar on April 6th called
yes.
Michigan Turns to Telehealth. So I figured you were going to mention that. So
yes. So just a little bit of background. So I've been doing telehealth actively since 2008. So that's 12 plus years. I always find it funny when people go, oh, let's start. And I'm thinking, oh, and I was late to the game. I was in Kentucky starting in 2008. My colleague had started in 1994. We are not talking about emerging. We are not talking about new. It always interests me when people say this new thing called telehealth, and I go, we're talking about 26 years in Kentucky. And they were not the first. So Alaska was the first. Well, technically going back, it was Boston between Mass General and Logan Airport, believe it or not. That was the first connection that was a civilian connection. Alaska has been doing it since the late 70s, early 80s. Kentucky got on board in 93, 94. But I've been doing it since 2008, and it's changed a lot. It has changed because technology has gotten cheaper, more compact. Connectivity has become amazing, as my presentation has talked about some of those things. So I won't get into that, but I think what I would like to talk about with you guys is, let's assume this pandemic is when people start doing it. My biggest concern, I wanted to pose these questions to the group, is how do you sustain telehealth beyond the pandemic? In the pandemic, it's necessary. People feel like they must do it. They don't have any other way. But what's to stop the complacency once people have no lockdown restrictions, people emerge? What is to stop people from going back to treatment as usual and abandoning telehealth to the way it was, both from a regulatory standpoint, payment standpoint, and clinician uptake standpoint, right? How do we sustain the momentum? It seems like it's hot, it's exciting, it's what you do now because you have to. But what if you don't have to? How many people currently doing it will abandon it and go back to treating or seeing or delivering care as usual? I'd like to pose that to the group and understand why that would happen. No one's doubting right now, everyone's jumping on board. I want to know who'll be left doing it 6 months from now, a year from now, assuming nothing else happens. But, I'm just wondering because I worry that might be the case, that everyone's on board and then people will abandon it. And then just the people who are doing it before will stay with maybe a few converts, but not any large scale adoption. Thoughts, group?
I know within the disability self-advocate groups and circles, it's being talked about a lot right now. Obviously, a lot of people saying, we've been asking for this for years and you've been so resistant to it, and now all of a sudden it's okay because everybody needs it. And so, what you could have been providing us this whole time, it turns out was possible, and you were just fighting against it. So I don't know if that would help convert some more providers, but it's definitely a pretty strong argument that is being made from self-advocates right now.
Yeah, what's interesting is if you read the language around recent CMS Medicare regulations, they've talked about in this time off, right? There will be reimbursement for home telehealth and this, that, and the rest. I don't know if all of these relaxing of regulations are temporary, because the biggest barrier to telehealth adoption has been twofold. Number one is regulatory and payment and other, barriers. And the second has been provider adoption. So if, let's say, they relax the first one and that improves the second, what if they clamp down again? What if they go back to, I'm sorry, you can't deliver it in this home, like they've had for the last 25 years. Home-based telehealth is not reimbursable. Now you have a problem again. The few people go, forget that. I'm not getting paid for it. I'm not going to do it, right? In disability networks and in the clients that all of us serve, this is so important from the beginning, because think of the barriers your clients face to see you in person. I have a cerebral palsy and a complex needs clinic, and Jane knows and seen patients like this. Megan has come and seen these patients with me. Do you know it's an all-day ordeal for a family to come in for a couple of hours visit? They have to get the child ready, put them in their equipment, take them out to the van. Some of the families have to order the county transportation a few days ahead, get them in, bring them in, parking lot, elevator, waiting room, rooming, for maybe an hour and a half. You spend 6-7 hours of all of this and the stress, and you got to figure out who's taking care of the other kids, take your day off from work, and you could have delivered that through telehealth. Now, I'm not saying telehealth is perfect. There are a lot of barriers, but people need to think about those clients, not the ones who can flip on their smartphone and their kids running around and everything's fine. It's the people for whom this is a game changer, the people who struggle to access us with care as usual. You know, they're talking about ABA right now and how hard it is to get in person. What is happening to all these kids, right? What is happening if you don't continue to deliver it in the home? Then you're going to drag them back to center-based and all this other stuff. I mean, we have to really ask ourselves, what's the long-term picture for our clientele? It is not perfect. I mean, for those who have done it, I did one day before, well, yesterday. It was a nightmare of an encounter, because the thing I can't control is on the family's end, right? I can't control their bandwidth. I can't control their volume. I can't control anything. It was an absolute disaster, but it was better than nothing. I always said to myself, oh, this could have been better, but it was better than nothing, because otherwise they wouldn't have gotten to see me anyway. She didn't have any handle on her kid, and she didn't have any handle on the technology. It was a complete nightmare to do, but I kept reassuring myself, it's better than nothing. I'm getting some data. I'm getting some guidance through. You have to be willing to compromise. Those who assume telehealth is the same as in person are going to get pretty upset, disillusioned, and not want to do it anymore. I'm hearing it from so many of my clients. I can't do an autism eval through telehealth. Forget that. And I'm like, you could do something. You could do a triage. You could get information. You could make their lives easier, because getting them in for an ADOS, ADI, this and the rest. Right now, our autism clinic is temporarily on hold, which means our 8-month wait list has just gone to 12 months, right? Because we're not seeing any more autism patients till end of May, which means all the March, April, May got moved to October, November, December, or whatever. What a nightmare that is. And so, you know, we have got to ask ourselves, how are we improving access if we go back to the way things were? And how much are you willing to compromise on quality for access? You know, that great scale. Great access, poor quality. Poor access, great quality. What's in the middle? I don't know. I'd like to hear from you guys, because telehealth is clearly not high quality for some things. It's terrific for my ADHD visits. It's terrific for me with my follow-up patients. Less optimal for my regular patients. Horrendous for my procedural patients, right? People who need a cognitive, and all my psychologists, they can't do anything with it. I can't do an ADOS yet through it. So, you know, it's an interesting situation. Thoughts?
Hello, I work in neuropsychology, so we've been addressing a lot of these issues too with evaluation and how that would look remotely. And I think, you know, a lot of us are exploring options that are, just as you say, kind of a compromise, you know, doing what we can to triage and, you know, to provide some, you know, immediate mental health, you know, addressing immediate concerns, see if there are other community resources that the family can access in the interim while they're waiting for potentially a longer wait list than before. And also, I think an upside or a silver lining from this is that a lot of, you know, by going through and talking individually with each family and meeting their needs, there might actually be some families who didn't need the full neuropsychological evaluation and really just needed that intake and the professional interaction and guidance. And so I'm not sure that that's going to be the case for most families, but that's something that we're, I think, hopeful for.
And Reed, that's a good point, right? Triaging them and giving guidance is better than nothing at all. If we maintain that we need to have high quality in-person interactions, well, they're not coming in, not under these circumstances. So something better than nothing is a compromise. I totally agree with, something that we've been trying to do, but it really depends on the provider, right? People who have been trained a certain way believe, as they should, that high quality is important. But at what cost? At what cost? Michael has a good point. Up in the UP, they've struggled with this for a long time related to access, right? And telehealth has its barriers. Michael's put it very succinctly, right? You've got weather barriers, internet connection. How are you going to get a quality eval like the one I had? Total nightmare yesterday. I saw the kid briefly. I heard what the mom said. He was running around. She kept changing room to room to room to try and get a better signal. It didn't work. What do I do? Terminate, or I get the general gist and then take it from there? I think that's the compromise. But people who think it's a easy fix, they're wrong, because they haven't done it long enough to know. It's a huge problem. I mean, it's a problem delivering medical care. It's a problem delivering behavioral health. It's a problem for applied behavior analysis, speech therapy. Not impossible, but you've got to individually decide your compromise, your specialty. Your specialty societies are less than helpful, sadly, because they're behind the curve. If you look to your specialty societies for guidance, they don't have a lot yet because they're waiting for the research, and the research is lagging behind everything else. So that's the risk. If they're looking for head-to-head studies looking at effectiveness, efficacy, and quality, those are going to take a long time. So we just have to move ahead without professional guidance from our societies, other than general guidance like do it, it's a good thing to do. Because you're never going to answer the question about is quality the same, better, or worse. I had put in a poster years ago about the only ones where quality was actually better was extremely disruptive, aggressive kids, because they couldn't hit me or hurt me. So I was seeing them through the screen, they're kicking the TV and yelling obscenities at me, and I was safe and I was able to do an eval. But other than that, I wasn't quite sure about the quality that I was delivering. Have other trainees on the call actually conducted telehealth? I'd be curious about, or anything, telepsychology, anything. Have you all conducted that? And what has been your individual experiences to share with the group?
So I know that I typed a little bit in the chat about my experience with being in the UP with telehealth. So NMU operates the Behavior Education and Research Center at NMU, or Bear Center. And I know like we have future plans to expand that, and they kind of want to call them baby bears. And so sort of have satellite locations throughout the UP where students or behavior technicians who they're either students or they can just be employed by the university who live and work in that area can work these satellite clinics and get clinical guidance from clinicians from NMU via telehealth. So increasing accessibility throughout the UP. It's difficult when, the concentration of clinicians are all in, the major areas like Marquette, and then, to go places like Iron Mountain, it's an hour and a half drive, and it really limits the, schedule, and it's prohibitive in how many cases that they can take on and still have the ability to travel to these sites and provide the supervision to the technicians that's needed for ABA services. So I know that that's something that they plan to do in the future.
Thanks, Michael. I'm going to for everyone to see until this month what Michigan allowed, until March the 16th, what Michigan allowed in terms of, let me see if I can print this, copy this. So the only places that Michigan actually allowed telehealth to be conducted, to be reimbursed, and I'll read this list out because I can't copy it: county mental health clinics, hospitals, physician offices, skilled nursing facilities, local health departments, tribal health center. That's it. No home, no school, where most of the children spend their time. So families would have to travel to their local center that was approved to get it done. Effective early March, they approved home. Temporarily, I don't know, or permanently, schools is still not there. So it limits where people can access it. What is the point in telling somebody from Marquette, let's say, that they have to drive to another town or from another town to Marquette in order to get telehealth? Home is a fantastic thing, and I'm glad Michigan's on board now. But it comes with all the limitations. Number one is I'm doing all these visits this last week and a half. I don't have any parameters. I have to ask the family, what's his weight? Well, we don't have a scale. What do you think? Somebody actually average measured their child's height for me. Well, if I'm 5'2" and he's about to hear, and I'm thinking, that's all I can do. But the limitation, if they were at a medical clinic, I would have gotten height, weight, pulse, blood pressure. It would help me with my medical decision making. This is unusual times, but with the home comes things like, how are we going to measure our patient's blood pressure when they are on medications that affect their blood pressure? Are we going to have them buy? Is it their problem or my problem to buy and ship them blood pressure cuffs? Are we going to have to train them how to use it? Can we rely on it? You know, things like that, pieces of data that you need. Same thing with any of you. I know that Natalie talked about OT and stuff like that. Can we reliably rely on families to deliver some of the interventions, or how much training has to go into training them to do this, right? If they're going to be our arms and eyes and proxies, how much do we have to take them out of their comfort zone in order to facilitate this? Great example was somebody, I don't know whether it was Kansas or somewhere, tried to do an ADOS in the home and had the parent try and do this stuff. My worry is, how much have you trained the parent, or do you just have them wing it? Go blow this bubble and let me position the camera, let me see where they're looking. I think the worry is, if you're going to rely on data for convenience that requires a degree of skill, then you have to train the person on the other side. I've trained my telehealth nurses and staff in places like Grace Health and South Haven and all this stuff. And so I can reliably say they're getting good pulse, blood pressure thing. They know how to position the camera. They know how to problem solve it. Doing it in the home is fantastic and family-centered. If it compromises the data you get, coming back to what Bree said, are we okay with a compromise? And at what point you say, I'm sorry, this is just not worth it, right? I mean, something to think about is a little compromise, okay. A intervention changing compromise, not so much. Dr. Turner pointed out Medicaid approval for telehealth in the home was there before, so it just so happened that it is there. We don't know yet if audio may be temporary. Audio is for some type of visits. Thank you, Dr. Turner. I do agree that, you know, Michigan is middle of the pack when it comes to telehealth for all the states. Just so you know, it's not a leader and it's not a laggard, it's somewhere in the middle. Home adding has certainly pushed it, but it's still not anywhere close, because they still don't cover what's called store and forward, which is where you can take a picture, send it in. So for example, somebody with a rash, certain types of birthmarks, etc. Take a picture, send it in, doc looks at it, tells you what to do. Or send a video in, right? For example, all of us know, what do we do with atypical behaviors? Is this a stim? Is this a tantrum? Be really nice if family recorded it, uploaded it, you take a look later on, send it in. You're not going to get paid for that. The language requires it to be real time, and it lets it be audio or video and preferably both. But store and forward is not covered in Michigan, so there are some limitations there. Video being sent ahead of time, audio, things like that. Not. Dr. Turner, can you opine on the fact that they do allow EEG reading through the epilepsy thing, and is that covered or is that just a grant? Because an EEG is not considered real time. Collect the EEG, send it to the peds neurologist.
So, am I unmuted appropriately?
Yes.
Can you hear me? Okay. I'm my hunch on that. I am not sure, but my hunch is that you don't get paid for the tele part of the EEG, but the interpreter can be paid for interpreting the EEG just as they would if they were doing it right. They were sitting in the hospital. So I think that's kind of like a radiologist reading an x-ray, could be off-site and reading an x-ray. You're getting paid not for the visit, but for the interpretation that could be in real time, be something that was stored for you. I want to comment barriers, and are we going to slip back after the COVID crisis is over? I think a big barrier has been the payment, of course, and inertia. Just why should I try something new when my waiting room is filled with people that I can see right here? Why do I need to do it differently? I think let's get over some of the inertia. I know from my own personal experience, I did telehealth for the first time yesterday. Besides, I've been doing phone calls forever, but I did it where it's an appointment on the schedule. Somebody at the front desk prepares it for me, and then I talk to them and I document it and I bill for it. And that was audio only at the health department. Works very well and can do a lot of things you wouldn't think you could do, like a 1 month well baby check. You know, I can get a pretty good idea of how the baby's doing. It is so much more efficient than having, like, for the family, but it's so much more efficient than us and having them come down the hall, clean up the room. It's just much more efficient. For the visual, I haven't had a chance to do that yet, but I was talking to my son yesterday, he's a family doctor in New York City. So they've moved to telehealth very quickly. And he was saying, wow, it's terrific. He said it went so smoothly. It had the amazing advantage. I could see them in environment. And I said, how do you do people with blood pressure cuff? They have something and they give me their readings. So he could really do it. So I think from the physicians who had this experience, I think many physicians who have been sort of ignoring it as okay, I don't need it, will take it because it's really, really, will it be paid for, and will it be paid for adequately? I think if we move more towards, I don't know. I mean, that's a big one. Now, the kinds of visits I'm talking about are not the kinds of visits, the challenging visits of the behavioral developmental evaluation. I couldn't agree with you more. It's one thing to follow up on ADHD, another to try to do an ADOS. I don't know. I mean, that's a whole nother bird. But I'm hoping that getting over the inertia will launch it, that we will be much better. Because, you were in an 8, I was going through files, and I was on some committees in 2000 where we were talking about using telemedicine to help improve services for children with chronic health conditions across the state. 2000, we're talking 20 years ago. The notes from those meetings were just the same as the notes from the meetings in 2018, just the same.
Yep.
How wonderful this is. We should do it.
Jessica had an excellent point. They had a class presentation for psychologists who use a telehealth platform called Doctor on Demand. That brings me to the point that many of you are trainees, and I'm wondering, how much emphasis has there been in your curricula? How much have you been taught over the years? You'll have been undergraduates and graduate students about leveraging video conferencing and telehealth in your practices. Because if you don't learn it as a trainee, it's hard to really adapt on the fly later on because you get set in your ways. So I'm hopeful that people are actually able to include it. Now remember, psychology has had guidelines from the APA many years. Ohio was the leader in psychology, telepsychology guidelines. I would say more 2003. So we're talking 17 years now. The problem is how many programs as part of the curriculum teach clinical psychology or counseling to use telehealth, show them, introduce them to the technology. That's important. I know Alexandra's saying a little bit in audiology. This is the issue, is if we don't include it in the curriculum, the practitioners of tomorrow are you guys. You guys will do best what you all are taught best. And if you all are taught mostly in-person delivery, you all will do that. You all will view this as a little fringe, a little uncomfortable. But if it's part of your curriculum, I'll tell you, in medical training, it's minimal. It is minimal. And that's a shame, because there are less barriers now, at least in medical students and residents. There's less barriers to telehealth education, and yet it's not being done. And so I really want I really want people to encourage not just the practice, but the teaching. How do we get lectures? How do we have live demonstrations? How do we ask questions? How do we get mentoring? Because you will do it better if you trained to do it. I learned it after being out of my fellowship 6 years. And then I quickly ramped up. But my fellow in UCLA, he trained with me on it. My resident currently seeing patients with me. So they're much more comfortable. They're learning about it. They're reading about it. They're seeing me do it. So it's easier. They're not having to teach themselves from scratch. So I really want more emphasis. You guys are leaders. You guys should tell your programs, hey, we know you guys are doing this, so you're thinking about it, but we want to be formally educated. Get us lecture series, get us a speaker, show us the ins and outs, teach us the things. Because if you have to do it tomorrow, it's so much better if you had a chance to learn it in training. And so, yeah, I've seen people have a lot of things, crash courses lately, a little bit here, a little bit there, part-time, short-term. Yeah, but if it's going to be something you're going to do regularly, and I hope it is, because our clients need some of it, just learn it while you still are in training, because you learn to test. Is it better to do it through a standalone? Is it better to do it on a smartphone? Is it better to have a dedicated device? Should I use Wi-Fi? All these things are all individualized. I couldn't tell you how to do yours, even though I've been doing this 12 years, because I don't practice the same way as you guys do. Each one of you has to say, what am I doing in person? What could I do to tell her? What's the best platform? What's the best technology? What's the best way? What are my processes? Let me break it down. Let me do it. Better to do it when you're a trainee, because then you will be able to practice and do stuff and feel more comfortable when you're out there in the real world. So just my little plug for tele-education is important, because just practice. I mean, there's a chance you'll be doing it wrong if you didn't have a chance to really do a deep dive into it when you had the chance. People are jumping on things. I had my colleague yesterday trying to get a quick crash course, as Batul was talking about, in 5 minutes, what I've taken 12 years to do. All right, he said, I got my phone out, I've got FaceTime on, I'm going to do it. I just said, I can't do this, Mark. I can't. This is not how you do stuff. Well, I'm going to go, and the patient's waiting. And he left. And I guarantee you that is a garbage encounter, because you haven't thought through everything. You haven't thought through everything. You're going to have your phone propped up. You haven't even tested to see how the connection's going to be. You haven't thought. And I understand it in a crisis, but think about this. You operate like that in a crisis and you feel good about it. When there's no crisis and you make that your standard of care, you're going to risk the fact that your quality is not going to stand up to scrutiny, because there's no crisis now. So you can't get away with nonsense. You can't get away with the partial anything. Do it right now, because people will forgive you if you make mistakes now. Don't take shortcuts now, because if you get into the habit of taking shortcuts now, when there's no crisis, you take those shortcuts and you have a crappy interaction. Families are not going to want it anymore. They're going to go, I don't like this, I'm coming in. And you go, but I want it. You're like, nope, that was a terrible encounter. And I've had families tell me there have been terrible encounters, and we problem solved it. And so, now's the time, trying to wing it between a partial this and a thing that is, for me, then don't do it at all. Just do it, as Dr. Turner was talking about, do a telephone. Because to do a bad video one, is actually worse than doing no video one at all. I mean, and I regretted the one I did yesterday, but in the big scheme of things, because I've done it so long, I could pick exactly what data was important to move this to the next phase. It wasn't a wasted visit. And Bree pointed that out. It was a good triage visit that would have not been possible otherwise. But can you imagine if you don't have the experience and the training to know when to take the best out of your telehealth encounter that's going south in a heartbeat? That worries me. It's just my little soapbox thing. So now's the time to practice, because at least for the next few weeks, everyone will forgive you if you're trying, but try to make it really good so it'll be excellent when you go. Good platforms, good connectivity, good policies. You know what my rule is, and I've always done it? I have a sign on my door. Telehealth visit, do not disturb. My door is shut. I put it on there. I throw a smart phrase in and I do it like that. I've been doing it for 12 years. If you don't have those habits, you're going to just shut the door and go, "Hi, Miss Smith, what's up?" Poor etiquette. It's just not cool. And somebody enters the room because you didn't put the sign up and you didn't tell people you were in room 16 doing a poor etiquette. No poor etiquette excuses. Good etiquette, best of your ability. So, but if you don't train to do it, I was trained by good people. You guys have wonderful teachers. Just train and get it done right. Mike, I will stop pontificating. I'm sorry. It's 6:26, Mike. I've been talking too much.
No, not at all. You have till 7, so there you go.
Oh, sorry.
No, you're all right.
Let's talk about barriers. Michael brought up barriers in the UP. Can somebody tell me about why? So, Carrie, you said none in social work. Why not? I'm curious. Why would a video encounter not be an important part of a social worker's sort of armamentarium? Same thing, but tool for audiology.
I think it is important, and it's definitely talked about. I just feel like a lot of the faculty are uncomfortable with it. Even now, teaching our classes virtually, a lot of the faculty are still uncomfortable with that even, which is kind of unbelievable in 2020. But yeah, there's a lot of anxiety around using technology in general for a lot of the faculty, even the younger ones. So I think that's really the issue. I don't think it's that anybody thinks it wouldn't be effective or beneficial to both sides. And I honestly, I think a lot of people still believe that it's not billable under any circumstances. So I think people are just uneducated on the policies around it.
And you may be right about the billable part because the guidance has been very restrictive in who's allowed to do it. So I'm pulling up the guidance now, and it looks like the only people who are allowed to do it are physicians, psychologists, social workers are included. But that's, and nurse practitioners, etc. So it infuriates me. Why wouldn't they include physical therapists? Why wouldn't they include a whole bunch of other people? They made it so restrictive medical when there's so many people doing so many important things. That I don't understand. And Jane, that is something that has not been loosened in terms of who is an eligible provider who can bill and collect. They may have loosened the locations, but the provider language has not been loosened. Any thoughts about that?
No, I haven't even heard the discussions about it. I mean, it might be kind of the idea of the assumption that a physical therapist has to be hands-on. But, I would guess just as with a surgeon, we wouldn't have surgery by telemedicine, but you could have a lot of the assessment and follow-up by telemedicine by a surgeon, and similarly someone who does a hands-on kind of profession therapy like a physical therapist. I think it's just, blinders on, just sort of assumptions of what people do. And, you can't do them. If you can't put your hands on them, how can you be a physical therapist? But I would think that having been to physical therapists, an awful lot of the work is guiding me, telling me what to do.
Because they're allowing orthopedic doctors and rehab doctors to do telehealth, but they're not allowing physical therapists to bill. So that is really, that doesn't make sense. It seems so restrictive. What about audiology? Because there's actually a lot of good work out there in audiology, but what are some of the barriers, maybe Batul or others, about teleaudiology? What things can and cannot be done really through distance?
So this is completely new to us, at least for me. We've been learning as we go along. Some of the programming software that we do can't be done remotely through telehealth. We've come to realize that. But I would say over the past week, a lot of patients have appreciated the telehealth encounters. Most of them, I would say, just want counseling and reassurance that they're doing it correctly. If we do need to change a fit or modify a hearing aid, we can't do that, but we can assess the situation and then they can come in. But again, same thing with billing. I don't think insurance would cover it, but with audiology, it's slightly different because a lot of the care is bundled when it comes to hearing aids. I know as they're transitioning to unbundled care, that might change, but I think a lot of it's just you need to be hands-on with the hearing aid.
And anyone in counseling psychology or able to deliver therapy, because for a long time, things like cognitive behavior therapy, parent training, etc., has been known to be effective. There's been enough evidence to say that it works. Have you all found barriers? Have you all found limitations in the world of psychology? I'm not talking about testing and neuropsych things and things, but I'm talking about counseling and training and things like that. Okay, Jessica said it works pretty well. That's the other thing is I don't know again about the training program. So we have interns who rotate with us, and I haven't been able to convince them to move to some telehealth models. Part of the issue is also that their university pretty much suspended a lot of procedures, but I would love, because we've been doing integrated behavioral health, and the clients have so appreciated having our interns deliver some of that. It'll be absolutely fantastic if they were to able to continue that, knowing that it is considered an eligible service and can be delivered in the home. I just haven't had a lot of traction with getting them, and I'm just wondering if that comes back to the fact that if it's not part of the DNA of the training, can you really just abandon what you've done and move this quickly? So Alex talking about telehealth audiology requires a lot of training, and yes. So yes, troubleshooting and certain things it's great at. Jessica talking about the therapeutic relationship take longer to develop. It's interesting that you say that, because again, the question becomes for a lot of our integrated behavioral health, these are short-term problem-focused encounters, and it's possible that they need a brief thing. They're not looking for a long-term relationship and alliance in order to address things. We often recommend they see a community-based therapist for that. But for brief, hey, I'm struggling with my kid's potty training. Hey, he's talking back to me. Simple things that otherwise they're delivering in the visit. It's possible to do. The trick, though, is getting both people comfortable with doing it. And I'm wondering if this is a golden opportunity to have a lot more mental health delivered, knowing that the research is showing that these type of isolation situations and lockdown increase mental health problems in the population. So if we're going to increase the problems and we have a potential mechanism that could help alleviate, I'm wondering why there's not more telepsychology and counseling going on right now. I'm just curious. There should be a wave of that right now. Anyone thinks that there are places which are telemental health? I have not seen that locally. I just don't know if it's happening at some of your other locations with psychiatry or psychology.
Hey, Neil, I can
I've
comment.
seen a couple. Oh,
Oh,
sorry, Mike.
No. Go ahead. You go first.
I was just going to say, definitely from, where I work, there's been talk of, kind of shifting our roles into providing mental health services for additional patients where that might not have been a primary part of our role, or even providing telehealth services for like medical providers who are working on the front lines of dealing with the pandemic. And I've also just incidentally seen on the listserv a couple of job postings for telehealth positions for mental health providers nationally.
Yeah, and I was just going to comment. I know a colleague at Great Lakes Psychology Group, and they've ramped up their teletherapy, and they've expanded the offerings that they normally would have.
Yeah, and given that in-home is allowable now, at least in Michigan, for reimbursement, it's going to be reimbursed. So I think that this is a great opportunity. I worry about these families who are cooped up, particularly the patients and clients we deal with developmental disabilities. I had a mother who's coming in for an urgent telehealth visit tomorrow because she has two adolescents with autism, one who is more severe than the other. And with losing his school and his ABA therapies, he has become unmanageable for her. At the same time, she's too nervous to take him to the ED or to some sort of urgent care because she's worried about that and worried about his mental health and his schedule off. So I'm going to do a little bit of reassurance and everything tomorrow when I connect with her. But this is a great example. There's some great resources out there, Mike, I'll try and share on how to share information and how to help individuals with autism during the COVID pandemic. That includes a little social story with pictures about what is COVID and what it's doing. I thought it was very sweet for some of our families and young with autism spectrum disorder. So they have resource list. It's coming out of the venerable University of North Carolina. So I do trust Sam Odom and their group to have some quality work. So again, you have to be careful with what you're giving, right? Because there are a lot of nonsense out there, and you want to hopefully get information from trusted sources. And I think the TEACH program, UMC, and the people who did the National Professional Standards are reliable in terms of autism-related information in a time like this. So I will send that link, Mike, shortly.
Great. Yeah. And we have we've started a resource page for COVID-19 for families on the LEND Canvas, so we can add that to there. And I think Lisa wanted to chime in on that as well. Yeah.
Yes. Can you hear me?
Yep.
Okay. So actually, first what I was going to say was I do see a lot of psychologists offering telehealth appointments right now since everything's been shut down. And personally, I actually had an appointment with a psychologist to deal with some grief of losing my sister, and I had to cancel it because there was some possibility of it was like right as everything was shutting down, but she did tell me that she is doing telehealth. So I have not done that yet. It's just been too crazy working from home and having my daughter home to get back with her, but I do know that. And in addition to that, one of the things we're talking about at my work at the Family Center in supporting families is I see there's a lot of talk of people who are concerned of, like you were talking about, Neil, in regards to having now children who may have a lot of behavioral issues and they're in the home 24/7 and these families have no support. And what's going to happen? I mean, for one, we have kids that are probably in abusive homes. I'm not talking about just kids with developmental disabilities, but now they're there 24/7 because schools are shut down. But then what about the parents who aren't really having to deal with it every day because the kids are in school, but now they're all in the home? And how can we help those parents from possibly getting pushed over the edge? And that's it.
There was also, we shouldn't forget self-care in this time when we are trying to address the needs of all of our clients and patients and stuff. There's some good guidance from the APA about what providers should be doing in this time as well, because there's an enormous amount of stress on all of us, right? And we are cooped in also. Many of us are fretting about our learning. Some are fretting about, their workloads and what's going to happen when all this settles down and they go back to work, current patient care, a lot of things. So there's some guidance, and I'll try and dig that up and send it, about you guys taking care of yourself. And that is important too. We try and be so helpful to so many other people who rely on us. We forget to take care of ourselves. And I've been coughing for 4 weeks and it's freaked me out. And then I took a deep breath and realized, I've not been taking my asthma medication like an idiot because I've been worried about when I need to go get tested. And once I started taking my budesonide again, I'm better in 2 days. And I was suffering through this because I'm freaking out about a mask and staying in my office and putting my hand sanitizer, and I forgot my basics. And this can happen to all of us. But, it's interesting, and people at work, go, and then they make you feel bad because you're coughing, and then you go and hide, and you feel bad, and then you go, but my patients, and I'm like, oh, what an idiot. The weather is changing, and this happens every year, and just go do your stuff. But, even we who are supposed to know better about ourselves, we're not doing a good job. So take care of yourselves, and I will dig up this link from the APA for providers so you guys can look at it and see what it means for you guys, not just for your clients and your patients. Other thoughts about either telehealth or going back, since we have some time, to the wearable novel technologies? Don't forget, and Mike, if you can reinforce this, because when I logged into Canvas, I want to be sure that people are submitting their deliverables to you so that I can review it. So I think when I checked, I wasn't sure how many had done it, but if you can make sure you send reminders out before the deadline.
Absolutely.
Important thing I want to bring up, and Wayne from Western had shared that with us, Mike. Important is about research and how we need to make sure that we are aware of the current research around telehealth and the gaps, so that if we are interested as leaders in neurodevelopmental disabilities, we need to partner with our colleagues in doing research in that field. So ABA, there was really good work coming out of different places, including Minnesota, about delivering telehealth by ABA. So I think one of the good things for each one of you to do is look at the literature right now, this week, next week, whenever. What is the evidence base behind your specialty, your field, and telehealth? Identify the gaps. Okay, it says this is good. And you guys have identified some of those gaps today in this conversation. And then think about, do I want to work on this? Do I want to collaborate with others? Because you will be cutting edge. Not many people are doing that, and LEND is all about interdisciplinary. And I'm sure Sharon would agree, as we think about research going forward, telehealth is a great example of interdisciplinary research, and how can maybe a speech therapist and an audiologist collaborate around telehealth and work together? How can an ABA therapist and a psychologist work together, right? How can we do this? How can a kinesiologist and a physician work together using telehealth? Because the great thing about telehealth is we can each be remote from the client and still collaborate, versus having them go to 2 separate visits and things like that. So, how can we collaborate? How can we collect data? And how can we then present and publish this stuff? I think that is key. Jessica's got up a good point that there are barriers when studying. So can you elaborate, why were you shut down by your IRB? That is interesting. Oh, your mic isn't working. Sorry about that, Jessica. But I find that interesting. I remember when we did that highly invasive study of cameras in the home, and we had that stuff. The IRB made us come in. This first time ever. Normally, IRB sends stuff back and forth. The 3 investigators had to sit in front of the entire IRB while they bombarded us with questions. And when they were done, they finally agreed, as long as we had that 9-page form or whatever, 7 or 9-page form, I forget, this was from 2006. But yes, they are looking out for privacy and ethics and things like that. But telehealth is not unethical. It's just not. It's different. And I think people fear the different. They believe that you're there to spy. The one thing I will advise you, unlike this Zoom session, which is being recorded, never, ever, ever record your telehealth encounters. Or if you do, make sure you have all your robust legal language beyond your standard consent to treat. Because of two reasons. One, I mentioned earlier, you don't have the bandwidth on your server to store large number of encounters endlessly. And number two is you shouldn't be keeping any health-related or privacy records anywhere other than your designated privacy platform. In most cases of healthcare systems, those are your electronic health records. The EHR has zero capacity to store video in it. It can store pictures in the media tab and this, that, and the rest. It has no ability to store video, which means you're going to have to find a different server or a local server. And now you're going to have to jump through hoops about, are you really keeping patient video somewhere? So I have never recorded, I never will. You can have parents record video of their own, share with you, but you shouldn't be recording them even if you have their consent, because it's going to be hard to know what to do with that. People go, oh, but it's good for training. You can have a trainee like this. I've had trainees when I was in Kentucky. I had West Virginia trainees from Morgantown in telehealth encounters with me. It works. Just don't record it because it's a huge problem. It'll lead to issues down the road, and the families then say, you know, you didn't adequately ask me. Rural telehealth toolkit. Yeah, so, you know, there's so many people providing guidance. The seminal guidance, I would say, comes from your original resources. So for psychology, it would come from the APA if possible, Ohio Telepsychology. For medicine, it's the American Telemedicine Association. I think Rural Health and USDA have been tremendous resources. All don't go to the companies for resources. Don't go to the companies, Doc on Demand, American Well, Teladoc, things like that, because much of the research they publish, sad to say, is colored by the fact that they either financed it or their employed physicians or providers did it. You want to have robust research and guidance coming from professional societies, not-for-profit organizations that have been doing this for years, because I really worry about these links that come in and they go, telehealth is really great. And then you scroll to the bottom and in small print it says, supported by American Well. And I go, yeah, are they going to do negative studies? You know, there's studies out there from UC Davis and other places say telehealth can be blah sometimes, can be so-so other times. I caution you, whenever you see something fancy, try and find the disclosures, because the disclosures will tell you a lot about how much you need to trust it. That doesn't mean that the companies are deceptive by any means. I just worry about the fairness about the data being presented. So we've covered clinical, we've covered education, we've covered research, clients, advocacy. Sharon, Jane, any thoughts about how our trainees can advocate other than with their own programs to have more training, more exposure? How can we advocate at the state level? How can we advocate at the professional society level? We have a room full of people of diverse backgrounds. What tools should they use to push for the fact that they are the clinicians and leaders of tomorrow? They want to make this happen for their clients. Are there any tools or guidance that they can go and sort of say, we want this done?
So I would say to advocate in their own institution is a good place to start. And the other is to begin to be involved, to lay the groundwork by being involved in their professional organizations. Just coming in with a particular issue, I mean, you can start coming in with a particular issue to advocate for, you know, telehealth is good, but it's more I mean, not all our trainees are at different points in their career. Most are early in their career, but not everyone is early in their career. Some are farther, kind of almost mid-career, but have taken a little bit of a change and are doing some training. But as you're maturing in your career, showing up, being there, listening to other people, coming to the table, and you can do this in in your professional organization or state committees. Trainees have had an opportunity to go, say, to the Autism Council or to go to the EDDI meeting or other multidisciplinary committees at the state level. Being there and participating in a number of issues, so you're not sort of seen as, oh, that's the if you always have one issue, people tend to kind of tune you out. So be involved and just lay the groundwork by building relationships and doing your homework, being an active member of the committee, and advocating over time. It doesn't happen overnight.
Yeah. Yeah, you have to start locally. You have to start with your own institution. So, for example, Jessica talking about the IRB in the past and stuff, I consider that an advocacy opportunity. How can I advocate my local IRB? How can I advocate my local people, institutional people, then start spreading out? And you can do them simultaneously. Dr. Turner's right. Do it with state level things. Just show interest because there's such a diverse group here. Not everyone's voice is always heard, but in telehealth, we all have the same voice. We demand access for our clients with disabilities beyond a pandemic, beyond the crisis need, because this helps their access and their lives. We understand its limitations, but we want you to make sure this doesn't die off. This continues, and we are willing to do the work. We're willing to problem solve it. We're willing to show you the pros and cons of telehealth. We want to be taught how to do it. We want to be supported to do it. Because if they see that there's a cohort of providers who want to, then they'll know that this is not just a flash in the pan for the next 3 weeks or 3 months. Sharon, are there thoughts on an AUCD, Great Lakes, LEND level that our trainees can speak up about telehealth?
Yeah, it's so funny. You must have seen the bubble over my head. I was literally thinking that is another resource. So I sent, and Mike has posted on Canvas, there is a webinar tomorrow through HRSA related to telemedicine, but I know it's a very high priority with HRSA in terms of, and it's been for a while, but I think that connecting through the AUCD network would be just looking for resources, and we can connect you to resources through AUCD. I think this would have been something that had, or even tomorrow, I think there are going to be virtual Hill visits related to the disability policy seminar. That could be another place to learn what's going on. And collectively, I think there's strength in numbers on a number of issues, and this being a high priority issue. And then we do, and Mike, maybe we could even bring this up when we have our next GLLC webinar. The topic that we're focusing in on this year is around equity and cultural competencies. But I think it would be a great place to infuse some of this in those webinars, and maybe even as a topic for next year.
I agree. I agree completely. And I think this obviously touches on equity in a big way. Because what you were talking about, Neil, and others have mentioned, that there isn't an equality of access to this service. And I think that's something that should be advocated for, and will no doubt receive a lot of attention going forward now.
Any final thoughts from anyone? We're almost at the end. It's 5 minutes to go. This has been so interesting, so timely. I was laughing when Michael was like, your topic and this week, I'm like, I didn't time it that way. But this is terrific. Last year we had a very different conversation. This year has been, there's so much, because last year there was a lot of, let me think about it. That's interesting. Oh, that's, and now everyone's like, how do I do it? What do I do? What's wrong? What's yes? Last year was more curious, and this year there's, as Dr. Turner said, absolutely there's some wearing away of inertia. And I'm glad. Well, 5 minutes to go. I thank you all. Don't forget, Michael, if you can remind them about their to-dos for the assignments that need to be turned in terms of reflection and stuff.
Yep, will do. And as always, if there's any follow-up to this, y'all can contact Neil directly. You can send things to me. And Neil, as you know, with everything and how it is now, we're really leaning hard on virtual experiences for all the trainees going forward. So just that being said, if there are any more, and there's a ton coming out now, of course, everybody's moving their conferences to a virtual format. So if there are any other resources like that, and this is for everybody on the session, send them along. I've received some great ones just in the last few days. So keep them coming. And of course, look for an evaluation tonight. That should be arriving in your inbox shortly. And I believe that's it. Anyone else have any announcements? Neil, we've been ending our Zoom sessions over the last week with everyone showing off their kids and their pets. So if anyone wants to show their dog or cat or gerbil off for it, it's been a nice, as Sharon calls it, a palate cleanser to end our sessions. Oh, I see one dog. Thanks, Natalie.
Baby, if you want to see
there you go.
this is Evan.
Hi.
Came on Pi Day.
Oh.
All right. Thank you all. And stay safe out there, and keep exploring telehealth even past these days.
For sure. Thanks, everyone. Have a wonderful evening. Take care. Thanks, Neil.